Now moving on to our second section, that is the bone fixation. As you know, in orthopedic surgery we have to fix the bone, which is called as osteosynthesis. This can be done by use of plates and screws, or we can use intermediate devices such as nails, or we can go for external fixation. In this section we're briefly discussing what are the indication of plate and screw fixation, what are different types of plate, and what different types of nails which are available. So what is bone fixation? Stabilizing two or more segments or fragments of bone is usually by internal or external fixation methods. If you see this, these both are actually internal fixation methods. That is, the implant which has been utilized is actually below the level of the skin. It's not out of the skin. Internal fixation could be by use of screws or plates, which could be a simple screw or a lag screw, which actually converts a rotational movement into a longitudinal movement, and hold the fragments of bone in a close proximity, allows healing, and fix an implant to the bone. That is, a plate can be fixed to the bone in form with help of screws. So internal fixation can be done in form of lag screw as well, which is actually, it compresses the two fragments by a lag principle. For example, this is the fracture line, and if we are passing a screw 90 degree or perpendicular to the fracture line, this will result in a lag principle effect. That is, it will compress these two segments in a way that it will pull this segment towards this segment. This is called as lag principle. It's usually done when we want to hold a certain fragment together, because it's actually if there's multiple comminuted fracture and we have 2 to 3 segments apart, we can fix by use of lag principles, and we can hold them together and then put a plate on it. It works best if passed in 90 degrees because the principle actually works at perpendicular to the fracture line. If it's a long fracture line, several screws can be inserted at different levels, as you can appreciate it over here. If it is single screw, can also be sometimes sufficient. Each screw is at 90 degree to the fracture plane. That is the most important point. If it's done parallel, it will not have its lag principle effect, or at their respective sides. So it can also be threaded only near its tip. So this basically, the principle applies is either you use a partial threaded screw, or if you are using a fully threaded screw, because this is going to be compressing this part as well. Therefore, what we do is we actually drill this area with a bigger drill bit and this area with a smaller drill bit. So actually it's not holding this very rigidly, but it's only holding this area very rigidly. Therefore, it pulls this fragment towards this fragment, forming a lag principle. Or other way we can do is we can use a partial threaded screw. That is, this side of this screw is plain and only the screw pitch is on this side. Therefore, it will pull this fragment towards this side. Internal fixation of the lag screw actually is called as pull-out strength, which actually depends on the factors involved in the screw in the bone. It increases with the diameter. The greater the large the diameter the screw is used, the greater its pull-out strength. If it's of large length, then it will have a larger pull-out strength. It will not be easily pulled out. Then thickness of the density of the bone. In corticals bone, if it is used, then it actually provides a larger bone strength as compared to the cancellous bone. Therefore, and the most importantly, the both cortices has to be engaged. Otherwise, if both cortices are not engaged, that pulling of the outer away cortex towards the inner cortex would not be actually happen. Therefore, to understand the lag principle, we have to understand this. There are two ways of either use a partial threaded screw, or if you are using a fully threaded screw, the inner cortex or near cortex has to be over drilled. So that, and plus this lag screw has to insert it at 90 degrees to the fracture line. Now this will help to cause the outer cortex or away cortex will be pulled towards the inner or near cortex. So that is what is important. Coming to the internal fixation, most of these other screws can also be used, actually inserted after drilling a pilot hole and tapping it. Only some degree of the tapping is done so that basically the screw can be inserted in a certain direction and there is no change of direction when we are inserting the screw. Self-drilling and self-tapping screws are not available and actually can be used. Instead of, we do not have to pre-drill them in the hole in the bone and then pass the screw on it. Cancellous bone usually are relatively osteoporotic as compared to cortical bone. Cortical bone is thick and cancellous bone is actually a kind of a spongy bone. So in cancellous bone, when we are dealing around the cancellous area, for example, in distal humerus or in these areas, for example, in the calcaneum, therefore we do not have to use too much of a tab. We can easily push the screw in without use of a tab. But when we're dealing with the cortical bone, pushing the screw in without tapping will require a lot of force, and with that force we can change the direction of the screw. Therefore the purpose of screw would be lost. Therefore usually in cortical bone some degree of tapping is done. When in cancellous bone we do not need any tapping. Coming to the cannulated variable pitch screws. Variable pitch screws are actually, what is the pitch of the screw? If you see this screw over here, the difference between these thread is actually the pitch of the screw. In the cancellous screws, the threads are more apart, therefore they have a higher pitch. In cortical screws, the threads are very near to each other, therefore they have a lower pitch. So that is how it's important. Nowadays there are variable pitch screws as well, in which some threads are close together and some threads are away from each other. So that is why they form a variable pitch screws. So screw advancement, as we screw it out, we actually results in a compression. K-wires are actually can be used, especially in case of we are using cannulated screws. Cannulated screws have actually holes between them, their segment. Therefore, they can be passed over the K-wire. We can insert the K-wire first, check the position, and then we can pass this cannulated screw over the K-wire so that it can cause compression. Basically, it can be used for other carpal fractures, capitulum fractures, and metacarpal head fractures as well. And these simple K-wires can also be used because we do not need a lot of compression in these areas. If you see over here, this is showing a diagram of the scaphoid bone, and actually the waist fracture of the scaphoid is being fixed by a screw called as Herbert screw or the headless screw. That is why the whole screw has actually gone in and caused the fixation without, and it does not have any head over the top of it. These are called the Herbert screws or the headless screw, which are used for especially for the scaphoid fixation. Now coming to the internal fixation, I've discussed the general simple screws, we've discussed the lag principle, and now we are moving on to the plates. What are the different types of plates which are available, and how we can apply these plates for the osteosynthesis and internal fixation of the bone. These could be straight simple compression plates, which is usually called as dynamic compression plates or DCPs, which can be used for compression along the plate axis. Countered plates, sometimes for example distal radius, olecranon, these have anatomical variations. Actually there are ridges and troughs which are present in the bone, therefore these plates have to be countered according to the anatomically to the area which is involved, and they are usually called countered plates or anatomical plates. They fit specific bone and they are specifically for usually right or left side of the body as well. Then there are low profiles or low contact plates as well. Why they call low profile? Because they reduce the footprint of the bone and preserve the local vascularity, as they do not damage the periosteum. Therefore there are factors such that they actually have a good union rate as compared to normal dynamic compression plates. Locked plates can be used as well. They have actually the mechanism such that they have two screw holes. One is a normal simple screw hole, another is a locking screw hole. Why these are locked screws are used? Because they are locked screws can be very helpful in terms of osteoporotic bone. If we are dealing with we are doing a plate fixation, let's say supracondylar femur fracture in an 80-year-old female, and she is severely osteoporotic, then we probably have to use locked plates, because locking plates would actually cause increase union rate and achieve higher degree of union with compared to non-locked plates, because the bone is osteoporotic. Now coming to the bridge plates, if you see this diagram, although the fracture line is not compressed completely, the screws are put over the top as well as at the bottom. This is kind of a bridge plate. A neutralization mode is actually on, in which the plate is just placed so that the bone is actually at least in the simple direction and will continue to heal. No compression is actually achieved at the fracture site. Then these are neutralization plates, which actually insert the plates which are inserted in neutralization mode are in terms of neutralization plates. That is, they do not achieve any compression at the fracture site, and they do not add any extra stability as well. So coming to the difference, for example, they can be applied subperiosteally or extraperiosteally. Now, subperiosteal is actually with the use of minimal invasive plate osteosynthesis or MIPO technique. That is, we make multiple small holes, then this plate can be slided subperiosteally without disturbing the periosteum, and by the use of fluoroscopy, they can be placed, the screws can be placed and drilled through the holes which are made. Although this is a little comparatively tedious and takes a little more of a learning curve, but overall it's very good for the bone because the vascular supply of the bone remains intact. Or it could be extraperiosteal, that is, we make a big incision, one big incision, we take out the periosteum and then put the plate in, and then stitch back the periosteum and all the soft tissue components. Although traditionally it has been placed extraperiosteally, but the problem is where the cortex which is actually on which the bone plate has been placed is actually ripped off its blood supply. So sometimes it actually leads to non-union. These are internal splints, as we know, because they are internal fixation devices, and they control the loads across the bone depends upon the degree of contact between the bone ends. So that is also important. If the two bone screws are not passing through the other cortex, this will not hold the plate together. Usually it's actually important on the work of the tension band concept, which is tension band concept is actually converting the tensile forces into compression forces. That is the tension band principle or concept. Now coming to the internal fixation, other internal fixation devices such as intramedullary nails. Why they are better as compared to the plates? One is actually they are the load sharing devices. Not the load sharing devices means you can ask the patient to start walking as tolerated as very early possible. For with the plate fixation, as they are not weight sharing or weight bearing devices, so therefore once unless the bone heals, then you cannot start the patient to walk early, so that the rehabilitation is actually delayed. Second option is they are actually intramedullary, so they do not actually affect the periosteum. You do not need to take out the periosteum before placing the intramedullary fixation devices. Therefore, in a way, they're helpful because most of the blood supply of the cortex is actually coming from the periosteum, not from the bone marrow. Therefore, interlocking nails are used most for the shaft fractures of the tibia and femur, especially the diaphyseal fractures. They actually fit in within the medullary canal, and it's kind of a provide not only varus valgus as well as rotational stability as well. And they control better control of length and torsion. Some are open and cross section because actually that is to reduce the damage they can do to the bone marrow, and then can be replaced by closed section devices. The important point is if you're passing an intramedullary nail for a femur fracture in diaphysis, now this can be done in a closed technique. That is, we do not need to open the fracture site, and we do not need to drain the hematoma. The hematoma which has happened being accumulated to the fracture site can will aid in actually healing process, and we can simply pass the nail from the trochanteric area or from the piriformis fossa or from the trochanteric fossa, and then we can lock it proximally or distally and provide the length and rotational stability of the bone, as well as allow the hematoma to heal the bone fracture quickly. Therefore, in a way, there's a better option compared to the plates because one, they're load sharing, they can be done by closed techniques, and plus they do not actually affect the periosteal stripping much as compared to the plates. So unlocked intramedullary nails are also available. They can be used for long bone shaft fractures in children. These are called the Ender's nail or flexible titanium nails. These can be flexible rods which are usually inserted into the children, especially with 5 to 10 years of age. The good part is because in children we have physis, which if this nail is actually passed, this will pass through the physis and will damage. Therefore, they have a different flexible nails which actually avoid the physis, and there is actually no damage to the physis. They also act as internal splints, and they actually have a 3-point fixation as well. That is, if they are passed like from distal part above the above the physis, the metaphyseal area, there is one point fixation, then second point fixation at the diaphysis, and third point fixation is at the proximal metaphysis. That is how the 3-point fixation of the flexible nail is actually achieved. And intermediate wires have a role, but usually in children. Now with the advancement of technology, flexible titanium nails have emerged, and they are actually a better option as compared to the K wires. Now coming to the external fixators. Internal fixation is although ideal, but not always an option. Therefore, we may have to temporary stabilization fractures required if they're open fractures, or for example, the patient has to be transported for the definitive care, or there is severe soft tissue joint injuries, or there open fracture as I just told you, or for example, there is massive bone loss and you need to reconstruct the bone and do the bone transport. Therefore, we have an external fixator in form of Elizarov as an option. Then during emergency stabilization of multiple bone fractures, for example, there was patient had a polytrauma, there was abdominal injury, there was head injury, there was femur, and there was tibial injury as well. Now with polytrauma, you need to at least stabilize the bone so that initially the abdominal injury and head injury can be taken care of. And once the patient is free of its abdominal problems and head problems are actually taken care of, then we can later on fix the bone. But by that time, bone has to be stabilized in form of external fixator. Now, what are the different options in case of external fixators? These include unilateral planar or circular. Now, this is example of a circular plane called as Elizarov. Unilateral means they are in one plane actually and control the motion in one plane only, usually. And then choice of fixator types depends on the intended purpose of use and surgeon's familiarity with the device. Elizarov is although slightly technical and it has a definitive learning curve. It's not easy for every surgeon to do the Elizarov surgery and deformity correction or kind of perform or apply an external fixator like Elizarov. But uniplanar external fixator is very easy to apply and can be applied by as easily possibly by almost all surgeons, especially in the ER and trauma care. Plus, actually, it takes a very short time to pass uniplanar fixator as compared to the Elizarov. So usually in emergency cases, uniplanar fixators are a good option, but when we are dealing with deformity correction, then probably the Elizarov is a better option because it corrects the deformity in 3 planes actually. So coming to the static and external joint fixation, rigid fixation for the short long bone, which can be achieved with form of uniplanar, although distraction can also be done in form of ligamentotaxis. For example, patient had supracondylar femur and so this knee fracture as well involving the proximal tibial metaphysis. Therefore, a distraction osteogenesis can be done, that we apply an external fixator in the distal diaphysis of tibia and diaphysis of the femur and distract the joint so that they do not actually collapse. It could be for comminuted intra-articular fractures. As I just told you, classical example is a floating knee situation in which there is a comminuted fracture in the distal femur as well as the proximal tibia. Or it could be for the ligamentotaxis, which can be later on used for the reconstruction may be required, and we do not want over the period of time, by the time fracture heals, the ligaments actually contract, and this will be disastrous for the patients. So that the ligaments are actually stretched out so that they can be later on, once the bone deformity is corrected, the ligaments and soft tissue contractures are not present. And then percutaneous K wires can be used along with another of circular frame because they are actually K wires used at a high tension actually provide greater stability. But with everything, there are always positives and negatives of all things. Usually with the uniplanar fixator, as when stabilized, sometimes the joints are actually fixed in one plane, and this can lead to finger flexion or stiffness or ankle stiffness when this delta frame is actually applied towards the lower limb. Then it could be dynamic fixators. Then there is a role of dynamic fixators. That is actually because they are not only fixing the bone in one plane but allowing the movement of the joint as well. And then there is a role of these dynamic fixators which actually, for example, allow the movement for proximal interphalangeal joint and elbow joint. There are hinge fixators for elbow joint, which are actually helping to stabilize the humerus as well as the radius, but they are also allowing the movement of the elbow joint so that the soft tissue contractures are actually not formed. Then usually they bend exactly at the axis of the rotation of the joint. In this section, we have briefly gone through the different types of fixation methods. We know there are internal splints or internal fixation devices for osteosynthesis, which include the plate, the screws, and the internal devices such as intramedullary nails or rods. Then we can sometimes we have no other option but to go for some kind of external fixation, which includes uniplanar fixators, external fixators, or multiplanar external fixators called as Elazarov. Keep watching sqadia.com. Thank you very much.